Good morning, everyone. My name is Dr. György Gulácsi from the Medical Imaging Center of Semmelweis University, and I will present my two projects that is ongoing in the translational medicine program. The first one is investigating the diagnostic accuracy of novel MRI techniques in patients with cartilage-forming bone tumors. So the majority of chondroid tumors are benign, and they are pretty common. However, chondrosarcoma, its malignant form, is quite rare, but it is actually the second most common primary malignant bone tumor following osteosarcoma. And accurately grading these chondroid tumors is needed because the therapy differs greatly among the different tumor types. But it's actually a pretty challenging task, because it needs a multidisciplinary approach with radiologists, pathologists, and clinicians. And unfortunately, conventional MRI protocols, which are needed to differentiate among the different tumor types, are not accurate enough right now, as of right now, and false positive cases are quite common in these cases. Lately, relatively new techniques were started to be used in sarcoma imaging. For example, dynamic contrast enhanced imaging, which examines the perfusion characteristics of tissues, diffusion weighted MRI, which is about how water molecules can move in a certain tissue, and lastly, radiomics, which is a post-processing techniques, and it is based on texture analysis of the tissue that we would like to examine. Our clinical question was how good these new techniques are compared to the traditional MRI techniques, and our hypothesis is that these new techniques are actually perform better in grading these tumors. So we use this search key in Forge large databases, and interestingly, we only found 12 eligible full text, and unfortunately, only radiomics had enough articles to have a quantitative analysis on them. DC and DWI MRI articles are very scarce in the literature. And we actually compared outcomes like benign versus malignant tumors. So we compared how good radiomics can differentiate between benign and malignant tumors, benign versus low-grade malignant tumors, and low-grade malignant versus high-grade malignant tumors. And because it was a diagnostic study, the outcome measures were accuracy, sensitivity, specificity, and area under the curve. Okay, and unfortunately, we had only enough data for the benign versus malignant differentiation, and that's the thing that we actually done in our analysis. And here are the results. As you can see here, we created 4 subgroups according to three subgroups according to the MRI weighing. Namely T1 weighted images, T2 weighted images without fat suppression, and without added contrast agent, and the other subgroup, which was all the other sequences in one group. And the subgroup was the expert group, which consisted the radiologists, and unfortunately only one article contained this information, the PAN article, and 3 radiologists' performance was measured in this. And as you can see here, the sensitivity and specificity in the radiomics model for T1 and T2 weighted images are quite favorable, but unfortunately the confidence intervals are quite wide, so it means that it is a bit unreliable, and we don't know how effective these techniques really are because of the small sample size, and the expert subgroups in the radiologist subgroup didn't perform very well comparing with the literature. And Here you can see the area under the curve analysis. Here you can see that only the PAN model had narrow confidence intervals, but if we dive deep into the data, this model is overfitted, because when it was tested on an independent test set of data, it wasn't that accurate, so it needs to be interpreted cautiously. So here are the summaries of our meta-analysis. So we use rigorous method selection criteria and inclusion-exclusion criteria, but the limitations are there, namely small sample size, low quality of results reporting. And the conclusion is that these data should be interpreted cautiously because of the insufficient number of articles and the poor quality of these analyses. And because of this, we were planning to do our own research on this topic on the from the National Bone Tumor Registry. So we plan to investigate the diagnostic accuracy on our own patient population. So actually, the clinical question was the same that we asked in the diagnostic meta-analysis. And we found 88 eligible patients, and only 42 patients was found, interestingly, in the PAC system of the Semmelweis University. So that's why, these patients, these studies were actually very heterogeneous, because not all sequences that we would like to examine was contained in these studies. So we decided to go in another way. A systematic review was published in a highly prestigious journal, European Radiology, and the authors used the technique, an analysis with all these sequences put together, T1, T2, and other contrast weighing, and they reported this result. So we asked that, can these MRI sequences be put together for radiomics analysis? Is this methodology good enough in the methodology department? And we, in our patient population, we examined the role of basic contrast weighing and role of contrast material. Can these sequences be put together for analysis? And we found 14 patients who had both T1 weighted images with and without contrast enhancement and a fluid sensitive sequence. And our methods was that we manually segmented these bone tumors with 3D slicer software, and we used 93 radiomix features, and we did an ICC analysis, quantitative analysis, how these features can be put together, if they can be put together, and we used the 95% confidence intervals for this purpose. And our results was that only 3% of these radiomix features are similar if we compare T1 and T2 weighted sequences. So they cannot be put together because most of them are pretty different. And if we administer contrast material, only 6% of the features are actually similar enough if we use the 0.8 cutoff value. So the conclusion is that they cannot be put together, they cannot be reported together because they are different enough. And we also use the AUC values to see how we can differentiate with radiomics between these sequences. And as you can see in the left side, there are some features that are good enough for this differentiation between T1 and contrast-enhanced T1 sequences, and there are plenty of features in the T1 versus T2 differentiation department. So summary, we had to convert our research because we don't have enough data for our original plan, and we tried to gather more data, gather and collect more studies from external hospitals to finish our analysis. Thank you for your attention.
Okay, I already see that there are quite excited audience asking questions, but first, congratulations, György. This was a huge, huge success in my opinion. Please.
Thank you. Great presentation. So I have a question about your first project, and specifically about the reference. You say the reference is MRI.
Yes.
Do you presume that MRI is 100% correct?
No.
So you're defining the true cases or false cases?
They were histologically proven chondroid bone tumors, so that's why the overall number of patients was so low, because most of these benign chondroid tumors are only followed up, and they are not. They don't have biopsy. These patients don't have biopsy. They don't have surgery. Only the questionable cases are biopsied or surgically removed. So that's why we only had this low number of patients.
So the reference is really then actually more the clinical pathological.
Yes. Yeah.
Because that is actually a common definition for reference, which can be used. Maybe it's going to help you. You can use the definition of either pathologically proven or upon 12-month follow-up, no imaging progression or disease progression was seen, which is a definition for benign cases.
Yeah. The clinical routine is that they are followed up by X-ray, because MRI is not that accessible, and the X-ray features can determine the growth pattern of the tumor. So most of the cases, if you just incidentally encounter a cartilage forming bone tumor, they are not proved via histology. They are only followed up via X-ray. So that's why we didn't include those patients in our study, because these X-rays are not accessible. These patients disappear, and you cannot reliably follow up all these patients. So that's why we used a harder inclusion criteria. Only the histologically proven cases were reported.
And for the meta-analysis, was then the reference really MRI, or was it clinical pathological?
It was histology in all cases, either biopsy or from the surgery, or from the sample collected from surgery.
Okay, I see. Thank you.
Congratulations on the presentation. My question is, what is the practice in Hungary? Like, do they do T1 and T2 sequence as well, and radiomics? So I have seen that you were surprised that you found only 14 patients.
Yes, unfortunately, I had only 10 minutes. I could tell this topic about 30 or 40 minutes. So I gathered studies, many centers from Hungary, and these sequences, the used sequences, were so heterogeneous that I was amazed that we actually found 14 patients who had these three very common sequences. So it is a very sad story, I think, because these conventional techniques needs to be done in a protocol-like manner. And if you lack these contrast, these sequences with those contrasts, it is not just bad for science, it is bad for clinical practice, because you cannot tell some features of the tumor in your radiological report. So it's unfortunately right now the status of MRI quality in Hungary, but it needs to be issued later by us radiologists, because it was for me a very surprising statistics. But yes, it needs to be addressed later.